Hi everyone, this is Hannah. I'm doing my CRACE presentation for you guys today. Basically, I've selected a client that has been at our center for a while, and I'm going to kind of present some things to you and ask some questions to you. So let's go ahead and get into this. So DMH, that is where I do my internship. We formerly were known as DMH, however, I think as of the beginning of this month, they have changed our name to the Department of Behavioral Health and Developmental Disabilities. So instead of DMH, it's BHDD. However, you're probably going to hear me refer to it as DMH throughout this whole thing. That is what I'm used to. That's what my badge says. So it's going to take a minute, okay? But we're going to get there. Sorry if I'm not like looking at you guys. My camera is at the top of my screen and it's high off the ground. So our mission statement is to support the recovery of people with mental illness. Basically, our main goal is to support people while they're on their mental health journey and kind of help them to overcome those mental health issues. Our funding, as you can see here, I've listed several things. This funding is predominantly the funding for the entirety of DMH as a whole, not just our center. In addition to this, I did find out that there is a $7.2 million award that DMH was given to improve integration of behavioral health services, which is what our name change and stuff like that has got to do with that. Basically, this budget is laid out to maintain 16 community centers. So we service 46 counties in all. That is all the counties in South Carolina. We have a center in every single one of them. So if you are in South Carolina and you ever need help, all you have to do is look up our website and we have a map, lovely map, that'll help you find the center that services your area, or if you ever need to provide those resources to somebody else. We also maintain 3 inpatient facilities. Those are, let's see, we've got, I'm looking at my notes, Bryan Psychiatric Hospital, Morris Village Alcohol and Drug Addiction Treatment Center, we've got William Hall Psychiatric Institute, and that is our NGRI, not Guilty Reason of Insanity, Outreach Clinic for Sexually Violent Predators. And we've got I always say this wrong, Werber. That's another center we have. Basically, all of those are going to have their own budgets. I wanted to provide our budget here at Spartanburg for you guys, but it does not get released into July, and even then I'm not too sure if I'll be able to have access to it. It seems like right now it's a little bit of a secret, but we'll see. Okay, here's our agency information. Well, before we get onto this, let me talk about that budgeting thing for a little bit longer. So in my notes, and honestly in class, I have mentioned several times that we are in what they keep referring to as a budgeting crisis. Basically, that means that we are unable to employ as many people as usual. We have to make cuts in areas, so that is affecting us now, but we're hoping that'll change in July. We'll see. So our agency information, we have a specific kind of structure. So obviously this is basically the governor. And the Mental Health Commission, the governor chooses who is over our commission, pretty much. So the governor has chosen this gentleman on the side. His name is Robert Bank. He's a doctor, and he's over the entire Department of Mental Health in South Carolina. He is top dog. He's our state director, and that's again appointed by the governor. Now each center does have a different chain of command. So I'm going to show you on the next slide the chain of command at the state level, but each center is very different. So each center, we have usually a director. Our director is Ebony Gaffney, Dr. Ebony Gaffney. And below her would be like each department head. So Department of Adult Services, Department of Children's Services, stuff like that. We have different departments, and then it goes so on and so forth, much like any other job. This is our little map. I know it's really hard to see. It was really hard for me to see too, but as you can see right here at the top, not too sure if you can see my mouse, not too sure if I can let you see my mouse right here. Robert Bank, he is the director. And then you go over here and we've got the director of different items, and everybody is under our director there. Okay, so the next one, who does the BHDD service? And what services does the BHDD provide? So we provide a lot of services to a lot of people. Let's get into that. Okay, so we primarily service individuals with mental illness, obviously. Typically, we service specifically low income, no insurance, or no income at all individuals. Basically, we offer a sliding scale that allows us to take these individuals and provide them service without having to charge them really high prices. Now, this does have a trade-off. While we are able to service these individuals, we are not able to service them maybe as frequently as like your traditional clinic would. So we service people all over the county. So we service individuals in contracted locations. So what that means is we have employees stationed at local jails, schools, homeless shelters, boarding homes, community locations, and just events in general that we put employees at to kind of work on stuff like this. An example would be the Heart. It's a local community group that kind of like helps homeless individuals with food and any other resources they might need. Like they have a dinner, I think it's every Thursday. I have been to it before, that we send staff to. So that, going along with what I just said, we service individuals of pretty much all ages. We do not service, now we do most mental health diagnoses, but we do not service a primary diagnosis of autism. We do refer out for that. We service individuals with mental health, substance use, developmental disabilities. We have inpatient and outpatient services. And then we have, I'm going to list them all for you. Maybe I'll go into them a little bit because there's a lot of them, but these are some of the resources we offer. So we offer CAF services, that's Child, Adolescent, Family Services. We have the school mental health counselors, community care, crisis. So we have a crisis team. They're really awesome. We send them out if, for instance, we get a patient that's calling us in crisis right now. We are able to send those individuals out there. That's mobile crisis. Let's see, we have deaf services, which is an awesome thing. We've got services that help for housing. We've got the jail and correctional services. We've got trauma services, towards local care, which is basically we send people out into the community to help individuals with maybe more severe mental illness or people who are struggling to make appointments. We have ACT, which basically is very similar to the other one. It's for patients with schizophrenia. We send people out to the community to help them get to appointments. So, addition to that, each center has its own individuals with specialties. So, for instance, we have a substance abuse counselor here. Not every center is going to have substance abuse. In fact, we send her to Cherokee and Union frequently. We also have individuals who are certified in different therapy techniques. So our overall sort of standard is CBT. However, we do have individuals who are certified in DBT, EMDR, I mean, all kinds of different things. And we also provide services in a treatment team structure, which is really awesome and really, I feel like, a very essential part of mental health care. Basically, what that means is your doctor, nurse, clinicians, and any other services are all going to be communicated within the team. So, for instance, if you have one doctor, that doctor is also going to be on the team with your nurse, who's going to be on the team with your clinician, and we're all going to be able to talk together to make sure that patients are getting the best care. Like if a doctor was to catch something that needed to be discussed a little bit more in a therapy session, then they would communicate that. So here is my client information. The client I chose because she has been at the center for a while, and to be honest, I really just am looking forward to some feedback about her because it's a very complicated situation at this point. The name I've chosen for her is Susan Smith. She's a female. She's 64. She's white, non-Hispanic. She is adopted. She does not know either of her birth family, parents, extended family, any of that, and she finished high school. So my client information from her ICA. So an ICA for us is initial care assessment. Every client basically that comes through the door is going to have to do one. Typically this is something we update yearly, but it doesn't, hers specifically hasn't been updated in a while, and that is not something that happens very often just because it is such a time-consuming process. So her ICA in particular was very, very difficult to read. She was a first admitted in 1998, as you can see here. And back then, we were still doing paper records. I say we, but I was obvious. I was not born yet, so just be aware of that when I say we. I was not here. So she was admitted in 1998. They're doing paper charts. So her ICA was very difficult to read. So there are some things that I was not able to put in here because it was really illegible. It was scanned in and you could just tell that it was old. So her ICA was done. She was brought in originally because she was a hospital discharge. She stated that she felt insecure in her relationships. And, you know, this is something that I see even today in her behavior, which you can see here. A lot of her problems were first marriage ended within 6 months. I didn't include it on here, but she was also in a relationship, but I could not kind of figure out when she had gotten into that relationship. Her diagnosis at admission was generalized anxiety, and her outcome was want to be on medication and overcome sexual and anxiety problems. So the last statement on her ICA was pretty interesting, I'd say. I understand that years are going to definitely change somebody, especially this many. I mean, 1998 to 2025 is a very big jump. But you'll see Susan, it's weird. As we get into the next couple of slides, you'll see it. But Susan has several phobias. She listed on her ICA she was scared of the dentist. I feel like that's kind of reasonable. I'm scared of the dentist, so that's fair. And the largest one here now is, well, here's where it gets interesting. Her largest phobia currently is her health and medications. And that last statement she put on there about wanting medications just really was interesting to me. So it's just interesting to see how much somebody can change over time. Okay, so I'm going to say that I do know that she was admitted in 1998, and the first numbers you're seeing here in 2008. Let me explain that a little bit. So with records being super difficult to identify and find within her records, the closest to admission clinical note I found was this 2008 note. I think this is because somewhere between the two dates we switched to the computer system, and what that did was they would only scan in the documents that were super important. For example, this ICA that we saw earlier. So I think that's the reason we're missing records. I mean, even after 2008, I did also find some documents that were still done on paper. For instance, her DLA 20 I found, which was kind of almost not legible, was a 56, and that was done in 2015, so way after, which, I mean, of course, now we can still do things on paper, but it's very uncommon for clinicians to do now. Let's see. I'm so sorry, I have a cough, I can't get rid of it. Okay, so her records pick up in 2008, where she expresses anxiety about her, where she expressed anxiety but appeared stable. At this time, she is working. So now, currently, she is not working. I don't know that I have ever heard her express any interest in a job. She does not work, which, I mean, now she's at an older age, so it's a little bit different, but at this time, she was working. In 2009, she begins expressing a phobia of doctors. At this time, she is able to receive treatment. So what I mean by that is she is very fearful of doctors in general. So right now, she would not go to the doctor and get a blood test done because she is so fearful of what the results will be. She's terrified of cancer. She's terrified of the doctors in general, so she doesn't go. Now, here she could go, and I think a little bit down this list, which I have included what I feel like is very important to her case. Down this list, you're going to see come to some of the reasons why I think I've identified that she does have this fear of doctors. Okay, at the following visits in July, she expresses a fear of aging. This is another phobia that we talk about even now in therapy. And she expresses it throughout several sessions. Okay, but she also put this in. This goes to now. So this is in most sessions all the way till now. So at this time, she expressed a fear of aging related to her ex-husband. He friended on Facebook, and she kind of ruminated on that, and eventually was able to identify that she was kind of associating her ex-husband with that time in her life where she was younger. In 2011, she spoke about her problems with her current spouse of several years. Now, this is something that she talks about even now. She seems she's scared. Well, she said she's scared to go without him, but she's not very engaged in the relationship itself. Well, let's see. Excuse me. Trying to keep from coughing. In March 2011, her mother passed away. Her mother was an elderly lady. She was very sick. So this is another thing that could contribute to that fear. Okay. Let's see, in May of 2011, she switched jobs. So previously, she had been in the same job for several years, and she switched. So sorry, y'all. I really am. This job switch showed her anxiety towards change. She complained about the job. She kind of expressed thoughts that kind of were not even like logical thoughts about this job switch. Like she was coming up with all kinds of things. December of 2011, a friend's father has cancer. Now, she was not particularly close to this friend's father, but she did express it. That kind of contributed to her feelings of fear towards doctors. February 2011, she became interested in Wiccan philosophy. She still is Wiccan. This is a good outlet for her, that she likes to do all the things that kind of go around that. She likes to collect the energy stones and stuff like that. October of 2014, Susan's current therapist continues to work on catastrophizing, I cannot speak English, thoughts. Basically, this particular patient has a habit of, like, she'll create a thought in her head and blow it out of proportion in a way that she will, like, convince herself that more extreme things are happening. So, for instance, the easiest example I think I can come up with is, like, you're going to a new restaurant and you think of everything bad that could physically happen of you going to that restaurant, so you avoid that new thing. That's kind of what she does, but with, like, everything. Let's see. Let me, actually, I have an example in my notes up here about one of the things she did. So she, in October of this past year, she attended a Halloween bash in Greenville, but they had to have postponed it, so they rescheduled it, and they didn't advertise the rescheduling that well. So she was doing her face painting thing, which is on her next February 2015, she starts face painting. That's a very big thing for her. She started face painting, and during this face painting, she started thinking about nobody likes her, and this, and like all these thoughts, all these negative, awful thoughts about herself, because she didn't get that many customers. But we had to work with her about illuminating the situation and kind of explaining that, no, I mean, that's not the conclusion we're jumping to. Like, they didn't advertise it well. Let's think about other variables in the situation. Okay, let's see. In September of 2016, she begins journaling. This is something she still does, really enjoys. She brings it to therapy with her, and then we kind of comb through the things in there. I did want to note that right now, she stops mentioning going out with her friends as frequently in her notes. This is something I see now. She doesn't like to go anywhere at all. So this is something that definitely connects to now. Okay, picking back up in 2017, her mother-in-law passed away. And around the same time, 2 of her friends were diagnosed with breast cancer. So she has been surrounded in a lot of cancer that contributes to her fear of doctors. She, she's experienced and personally interacted with a lot of cancer patients. So that's where this fear is stemming from largely. So in 2017, she closed on a home. This is important because it ends up causing a lot of stress. And prior to this, while they were looking for a home, she was pretty stressed about it as well. In 2019, she was transferred to a new mental health professional. Honestly, I feel like this was not great for her. If you reflect with her notes, they're a little bit, they become a little bit more negative, and like she's not progressing quite as far. March of 2020, well, I skipped one. November 2019, she mentions the first thing of self-harming. I have not heard her personally mention any self-harming, but she said that this came after a meltdown, and this is not the last time I've seen it in her notes. let's see. March of 2020, COVID hits. So she is, well, during this time of the new house and COVID, she also has a lot of crisis appointments. COVID brought on a lot of fear for her. And she also butted with her spouse a lot because they were living together and they were both off work, and it was like a big thing for her. Let's see. In November 2020, she began reporting a lack of energy and to be productive. March of 2021, she began some peer support services, but only attended a few of them. July 2021, she transferred to another MHP to receive EMDR services. Now, to establish that she needed those services, she scored a 24 on the depression scale, which basically means moderate depression. Let me make sure that I'm telling you right. Moderate depression, yeah. So, and actually, I was looking through her chart, and it looks like she stayed with this MHP for a little while, but she never actually received EMDR services. In June of 2022, she began expressing concerns about politics. She's very frustrated with them at the moment. So this becomes a bigger deal to her. Politics and especially how they affect women really affect her. She had an abortion in the 80s and feels like it should be an option for everybody. So she expresses concern about this a lot. In 2024, she was transferred to another MHP. Unfortunately, this happens a lot in our center just because we have a high turnover rate. Okay, here is our last page of detailing care of this patient. August of 2024, Susan begins to state that she's terrified of everything. This is a concern because she mentions it a lot. I mean, it almost at every session. In October of 24, she reports being fearful of the events of the hurricane and expresses concern for her ex. This is the first time I have ever heard about her ex, though reading her notes, he kind of had a lot to do with her fears of aging. So she's still expressing political concerns, worries about aging. That was in November of 2024. During that election period, she shut down pretty bad, and she had a pretty bad time. February of 2025, Susan reports significant anxiety. She notes that she searches for information that will upset her. So what she means by this is like friends that she's not friends with anymore. She'll go look up their Facebook pages and look for information that she knows will upset her. March of 2025, she reports not being able to visit a friend in the hospital because of her fear. She is at this point so fearful of medical anything that she is terrified to go to the hospital, to go anywhere like that. In May of 2025, her husband lost his job. And in June of 2025, she reports feeling betrayed by the world. This was her last visit. We have not seen her for July because she only comes every about 6 weeks. Sorry. I'm trying to keep from coughing. I'm so sorry. Client-clinician relationship. So the client has switched MHPs several times, but seems to have a good connection with the one she's with now. So the one she's been with now has been her MHP for about a year. She seems to be open and willing to talk to her. With me, I don't directly interact with her a lot. A lot of what I do is shadowing, but she seems pretty comfortable with me for the most part. One factor that I think might hinder our professional relationship is my age. So she is sensitive to aging, and I sometimes am concerned that my age might affect that a little bit more. Okay, what interventions have taken place? So the most notable form of intervention that is used with this client was cognitive behavioral therapy. This is the primary mode in our practice, so it makes sense that that's what she's received a lot of. There was a small patch of peer services. These seem to actually work really well for her. She would not commit to coming to them frequently. The client was referred for EMDR, but seemingly never received services for it, like I said earlier. She's referred to DBT groups, but didn't show. We think that DBT could be really effective for her because she tends to jump to worst case scenarios, so some of those de-escalating tactics in DBT would be very effective. The client is currently receiving CBT with the MHP. She takes Vistaril, and Vraylar. So though she is scared of medications, we were able to get her to take them. She experiences severe anxiety, does not leave her house most of the time, and struggles to get out of bed to complete everyday tasks. Now we have got her to where she will garden and do things that she enjoys, but it's sometimes very hard for her. Her current plan of care focuses on reducing radical thoughts and emphasizing her strengths, which we will get to in the next couple of slides. Okay, so her current diagnosis is a little bit different than it was at admission. She now has major depressive recurrent episode of moderate, persistent depressive disorder, and generalized anxiety disorder. So we've added a couple. So her goals are to identify my strengths. These are her quotes. So when we do goals at our center, we like to take quotes and we work on them together. So I identify my strengths and use those to improve the way I feel about me and my relationships, and then work on radical acceptance and positive future planning. What interventions work? So currently she has generalized anxiety diagnosis. Treatment for generalized anxiety frequently uses cognitive behavioral techniques to reduce excessive worrying. Using CBT, clinicians can change anxious thinking patterns and address catastrophic thoughts, which are a lot of what she's having. Research approaches support. It also supports the use of CBT with minor phobias. So I'm not sure if that really qualifies. It depends on, I guess, how you look at it and what's just actually effective for her. And then DBT, I've also mentioned down here, is good for depression and anxiety and may lower the rate of self-harm by incorporating DBT mindfulness and awareness skills. Okay, so here's my ethical concerns. The client has been open since 1998. Y'all, that is a long time. Her symptoms have fluctuated occasionally. She did a little bit better from like 2015, 2016, 2018 in that area, but when she switched to MHPs for the first time, I think that I could see a definite difference in progress with her. She still has severe anxiety and depression symptoms. And my question for you all, especially that y'all can be thinking about before we do our class, is what point do you refer a client that is not improving out? She has met goals on previous POCs, but her main reasons for therapies have seemingly not improved. So she's still having those thoughts and she's still experiencing the anxiety and stuff like that. So what point do you think we should refer a client out for not progressing any? And then I've had certain clinicians here at the center tell me that sometimes you just have patients that are for lifers. And do you think you agree with that? I'd like to know your opinions on that. Okay, what comes next? Her plan of care. So as you can see, we've got those goals that she established. Objective on this goal is the client will describe in each session an example of personal strength and one strategy to incorporate that strength towards an activity that supports a value from her value sort activity. So I did not write these goals, but these are the goals that we're operating off of. Intervention, MHP will help client identify strengths and activities and improve self-worth. The next one is client will describe how she applies radical acceptance to thinking to moderate anxiety and depressive thoughts regarding uncertainty. MHP will help the client identify how to change habit by changing thinking rather than engaging in a pattern of these thoughts to what she perceives as stressful events. Here are my references. So be thinking about those questions, and when we come back next Tuesday, I'd like to hear your answers.